Hello, everyone, and welcome to the Tune Into Safe Healthcare webinar series featuring today's presentation, Making Dialysis Safer for Patients, IPC and Me, Tasks, Techniques, and Teamwork, hosted by the Centers for Disease Control and Prevention. My name is Stephanie Booth, and I am a public health analyst and an infection prevention educator contracted with the Division of Healthcare Quality Promotion at CDC. This webinar is part of a series of infection control related webinars that CDC hosts along with a variety of external partners and experts through the Tune Into Safe Healthcare series. Before we get started, we have the following disclaimers to mention. And also our disclosures. CDC, our planners, our presenters, and their spouses and partners do not have any disclosures. The next two slides include our continuing education information. I will go through them slowly to allow you time to read these slides. Here is the first one. And here is the second one. Although the CDC is accredited by the Accreditation Council for Pharmacy Education, as a provider of continuing pharmacy education, this webinar is not accredited for pharmacists. All participants today are muted during the webinar, but please feel free to add any questions you may have in the Q&A section at the bottom of your screen. At the end of the presentations, we will address as many of them as time allows. Our objectives for the webinar today include the following: identifying IPC techniques that reduce the risk and spread of healthcare-associated infections, describe IPC practices as seen through the eyes of frontline staff, examine the different roles of dialysis staff and how their actions can reinforce IPC, and discuss strategies for successful IPC adherence and for incorporating best IPC practices into your daily practice. And now I'm going to introduce the next four speakers. Nicole Galandi is a nurse infection preventionist with the dialysis safety team at CDC. Nicole's current work includes coordination of dialysis infection prevention projects and consultation on dialysis outbreaks. Nicole will be presenting some observation data and will serve as your moderator for today's webinar. The next three speakers I will be describing, they will describe their roles in outpatient dialysis facilities. First up is Brittany McFarland. In her day-to-day role, she manages a dialysis facility and all that comes with it. Additionally, it is not uncommon for Brittany to work the floor as a certified clinical hemodialysis technician, or CCHT. And today she is speaking to us from her experience in that technician role. Next is Kelly Richardson. In her day-to-day role, she functions as a manager of clinical services and works with facilities to make sure they are survey ready. She focuses heavily on infection control practices, and today she is speaking to us from her tenured experience as a dialysis nurse. And last is Michelle Murtha. In her day-to-day role, she is a clinical nurse manager who focuses on patient care from A to Z. Today, Michelle is speaking to us from the perspective of her role as a facility infection manager. So Nicole, why don't you go ahead and start us off?
Thank you, Stephanie, and good afternoon, everyone on the line. So as Stephanie just mentioned, my name is Nicole Galandi, and I will be presenting on the Infection Control Assessment and Response, also known as ICAR, observation data. And before I get too far into the presentation, I thought it best to ground us in some background on outpatient dialysis and the risks of infection. So starting with the national numbers for dialysis in the United States, there are over 7,500 outpatient dialysis facilities and over 500,000 individuals who receive hemodialysis in those facilities. However, the layout of those 7,500 facilities varies quite a bit from one to another. So I always like to say that if you've seen one dialysis facility, that means that you've seen one dialysis facility. It would be ideal if I could tell you that all dialysis facilities look the same or even similar, but that's just not the case. Dialysis facilities can look very different depending on any number of reasons, including their physical location, if they are a new facility or were built to fit the building that was purchased for them, or even the design used by the parent company that operates the facility. So looking at the pictures on this slide, you can see that dialysis facilities can be very long and narrow as depicted by the first picture, or they can be set up in L or U shapes where the chairs all rotate around a central station as depicted in the pictures in the middle and on the right. So it may seem silly to discuss this, but the layout of the facility will change the flow of staff and patients, as well as how infection prevention practices are performed. So it's something that I like to point out. Moving from facility design to the infection risks for dialysis patients. Patients who undergo hemodialysis have an increased risk for acquiring infections due to frequent use of catheters or the insertion of needles several times a week, which can introduce organisms into the blood and increases their risk for infection. They also dialyze in stations that are close to one another. They have weakened immune systems and have frequent hospital stays and surgeries, which increases their risks as well. And all that being said, I like to point out that healthcare providers can help decrease these risks and help prevent infections by following some basic infection prevention recommendations. So those recommendations are known as the CDC's core interventions for dialysis bloodstream infection prevention. For the sake of time, I can't go into too much detail on these recommendations, but these core interventions highlight things that staff, patients, and their families can do to prevent bloodstream infections. Research has shown that when facilities followed these core interventions, they cut their access-related bloodstream infections in half, and that those reductions in bloodstream infections were sustained for 4 years following the start of their use. For those that are interested, I've included the link to where you can find the core interventions on our website on the bottom of the slide, and I'll slide those into the chat here in a little bit as well. So now I'm going to move on to describing the Infection Control Assessment and Response, or ICAR program, and the observation data that was collected. So the ICAR form was created by CDC in 2015 to assess the infection prevention and control practices of outpatient dialysis facilities. These assessments were completed by public health departments across the country and consisted of 2 distinct pieces. So the first piece, there was an extensive question section, which was completed through discussions with dialysis facility leadership on policies and procedures for infection prevention in the facility. And then the second piece was the direct observation of clinical staff practices by public health department staff using CDC standardized audit tools, which I'll show you in a bit. For today's presentation, I'm going to focus on the direct observation of clinical staff practices moving forward. So this slide just shows you the cover sheet of the actual ICAR form, where you can see the description and the different sections of data that were collected. Section 3 is the direct observation of facility practices that I'll be discussing moving forward. And then this slide shows you the 7 standardized audit tools that have been created by CDC and that were used by the health departments to complete those observations. And I'll go through each of these in a minute as well. And finally, before I get into the individual observation results, data collection occurred between March 31st, 2015 and March 30th, 2018. The health departments completed 764 ICAR visits during that time, which resulted in over 70,000 observations. While this project occurred before the pandemic, to our knowledge, this is the largest data collection reported to date of standardized infection prevention and control observations completed in dialysis facilities. And now let's move on to those results. So starting with hand hygiene observations, which is the only opportunity audit included in the CDC observation tools. So the goal of the hand hygiene audit tool is to quantify the number of times a staff member performs hand hygiene when it's indicated over the total number of opportunities observed when hand hygiene was warranted. So as you can see on the slide, out of over 42,000 observations of when a hand hygiene opportunity was warranted or should have been done, 38,169 of those were completed successfully. So when we do the math, that results in hand hygiene having been done successfully 89.5% of the time. Moving on to the injectable medication administration observation tool. This observation tool and the rest that I will go over involve observations of procedures, which involve multiple steps. So for an observation to be counted as successful, all of the steps had to be completed. If even one step was missed during the observation process, that observation was considered not successful. So as you can see on this slide, this observation tool includes steps for correct transport of the medication to the patient station, performance of hand hygiene, putting on of clean gloves, disinfection of the injection port, aseptic administration of the injectable medication, point of use discard of the syringe that was used, removal of the gloves, and then another hand hygiene step. So for this procedural observation, there were over 3,000 successful observations for 3,550 total observations, which gives us 87.3% successful observations. Next is injectable medication preparation. And for the sake of time, I'm not going to go through all of the steps for the rest of the procedural observations or the numbers for each like I did on the last one, but you can see those on the slide. And that being said, 82.1% of the injectable medication preparation observations were successful. 82% of the catheter connection observations were successful. 77.3% of the AV fistula and graft cannulation observations were successful. 65.8% of the catheter exit site care observations were successful. And last but not least, 62.4% of the routine disinfection of the dialysis station observations were successful. So if you noticed a pattern to how I presented the observation data, you may have realized that I was going from the highest success observations to the lowest success observations. And I know I just presented a lot of information, so I wanted to do a summary slide to bring everything back together. So as you can see, the most successful observations were hand hygiene, injectable medication administration, and injectable medication preparation. I'd like to point out that research shows typical hand hygiene percentages for all healthcare providers is typically less than 50%, but in the dialysis setting, we appear to be doing pretty well. However, I will also say that the staff knew they were being observed by the health department staff, so that percentage may be higher than normal practice. The low success observations included routine disinfection of the dialysis station, catheter exit site care, and AV fistula and graft cannulation. During this project, the Centers for Medicare and Medicaid Services, or CMS, changed the station disinfection regulations to require patients leave the station prior to staff beginning to clean, which was required on our observation form. That change may have affected the results for this observation. However, staff are routinely asked to complete station disinfection while simultaneously caring for multiple patients and often without much time to complete all the steps required of them, which makes adherence to all of the steps for this observation tool very tough. And before I finish, I want to encourage everyone listening to think about these observation percentages in a different way also. So when you flip the percentages to think about the percent of time these practices were completed incorrectly, it changes the perspective a bit. So despite the high hand hygiene percentage, there were still 10% of the hand hygiene opportunities missed. And because we had over 42,000 total hand hygiene observations, that 10.5% equates to over 4,000 missed hand hygiene opportunities. The total number of observations for injectable medication administration was lower at 3,550, but that 12.7% means a step was missed in over 450 observations. And when you look at the low success observations, things look even more bleak. So almost 40% of the time, routine station disinfection was performed incorrectly, which is over 2,700 observations. And when we think of the results in this manner, it shows that there's a lot of room for infection prevention improvement. And I'll end by highlighting a few things that the next few speakers are going to discuss. So first, due to the nature of how dialysis staffing occurs, the technicians and nurses have a great deal of responsibility and can influence how infection prevention processes are implemented. Communication within and between these two groups is essential for infection prevention within this really fast-paced clinical environment. And staff should be able to recognize and tell one another if an infection prevention step was missed. In addition, patients should be able to speak up about infection prevention practices without fear of retribution. Facility leaders in dialysis facilities set the stage and the culture for how infection prevention is viewed in the facility, and they must ensure observations are being done in a realistic manner, meaning every observation isn't always 100% because that's just not possible, right? And not assume that staff remember and follow all of the facility policies 100% of the time. So observations are a more accurate way to see how staff perform tasks and procedures that prevent infections. And finally, including the voices of patients, technicians, nurses, and those who focus on infection prevention in quality improvement or process changes occurring in the facilities is essential so they can provide valuable input. So that concludes my portion of the presentation, but as Stephanie mentioned earlier, I am joined today by 3 frontline staff who will share their experiences as a technician, a nurse, and an infection prevention manager. They will identify and describe their different roles and walk us through how their daily tasks relate to infection prevention and control. And then after their presentations, we're going to come together as a panel to discuss what they share and answer some questions. So now I'm going to hand things over to Brittany.
Thank you, Nicole. My name is Brittany McFarland. I am the facility administrator of Mesa County, DeVita, in Grand Junction, Colorado, and a CCHT. Using and maintaining the correct IPC technique when preparing our patient stations and providing patient care is of the utmost importance. Policy and procedure states that our teammates must wash their hands upon entry of the treatment floor. We must don clean gloves and PPE before preparing the patient station or providing patient care. Additionally, we must wear a shield or protective eyewear before we come into contact with blood or bodily fluids. It's never acceptable to touch any part of the machine or provide patient care without clean hands and gloves before, during, or after treatment. While charting chairside, we sanitize our hands with the hand sanitizer available at every chairside station, while the patient's treatment information, then sanitize our hands again. The chairside charting station is considered a clean area. Gloves are never to be worn while charting, and we must sanitize our hands before and after use. All clinic teammates must wear a fluid-resistant PPE coat with every button fastened, masks, gloves, and safety glasses or shields when providing direct patient care. While accessing the patient's CVC catheter, there are strict infection control practices enforced throughout the training of our new teammates and after. CVC catheter and bloodstream infections are a leading cause of death with dialysis patients. Needless to say, our team follows every step to ensure our patients are safe. Cannulating a patient's AV fistula or graft has specific steps that adhere to infection control. We use alcohol wipes to prep the site for cannulation, followed by Accept, an antimicrobial cleanser, following the proper guidance regarding dry times before cannulation. We sanitize our hands and change gloves frequently throughout the initiation and termination of dialysis treatment. Other duties may include maintaining our patient's vitals, monitoring the patients throughout treatment, providing monthly patient education, preparing and administering heparin and lidocaine, infection control auditing, OSHA auditing, troubleshooting dialysis equipment, and maintaining our education through DaVita. Patients that have the ability are required to wash their hands and access upon entry of the treatment floor with warm soap and water. Frequent glove changes, posted signs listing clean and dirty areas, the consistent sanitizing of med stations, counters, door handles, and high-touch surface areas are a vital step in preventing the spread of bacteria. DaVita posts patient education signs in high-traffic areas that include preventing the spread of the flu, proper hand washing techniques, and other infection prevention reminders. While cleaning patient stations after treatment, we do not start the disinfection of the machine, chair, and surrounding areas until the patient has left the treatment floor to avoid cross-contamination. After the patient has left the treatment floor, the team uses the correct ratio of bleach to water, 1:10 for visible blood droplets and 1:100 for all other disinfection. Open the chairs to full capacity, wipe them down using a new towel for each section, let them dry completely, and then welcome the next patient in. During this process, we clean the entire area that surrounded the patient, including the wall box, counters, machine, chair, TVs, footrests, countertops, etc. The wall box is always clean last, and our hands are sanitized immediately after. Maintaining consistency with policy and procedure, along with proper infection control practices regarding the training of our new teammates, is absolutely vital. The quality and accuracy of new teammates' training determines the development of habits carried into our teammates' daily practice. Education does not end when our teammates finish training. Education persists throughout our careers on a daily basis. The RN is a leader on the clinic floor. They monitor and enforce standards of care for all clinic teammates and patients. Our team is expected and encouraged to hold one another accountable for quality patient care. Tenured and new teammates coach each other on observed and correct IPC techniques. If a trend develops, the facility administrator and RN retrain and re-educate that teammate. If use of incorrect IPC techniques are documented and addressed whenever they occur. We provide monthly patient education ranging on topics with infection control prevention at the top of the list. The team and patients have open dialogue about best practices on a regular basis. Upon entry of the treatment floor, the patients are reminded to wash their hands along with their fistula or graft with warm soap and water. CDC hand washing guidelines are listed at the patient's sink. If our patients are able to hold their own sites when their treatment is complete, our patients are trained to sanitize their hands before applying a clean pair of gloves and again whenever they are finished. Repetition, training, communication, education, and consistency are the practices that allow for adherence to IPC in daily practice. Secure, approved translation lines are used to educate patients with a different primary language to avoid miscommunications and misunderstandings. Now I'm going to, here are the signs. I'm going to read them for you. Cover your cough, armor up, flu down, and scrub the hub. About the cleaning of CVCs. Now I'm going to pass it on to my colleague, Kelly.
Thank you, Brittany. My name is Kelly Richardson, and I am the Manager of Clinical Services for DaVita. I have been a dialysis nurse for 21 years. I started as a PCT while finishing nursing school and then transitioned into the nursing role. I went into this field so that I could be an advocate for patients, and although I was able to do that in my facility with a small number of patients, I felt that taking the MCS role, I could be an advocate for a larger group. What I found was that not only can I advocate for our patients, I get to do the same thing for our teammates as well. I cover 19 facilities throughout Colorado, and in my role, I support my teams through survey readiness, education and training, infection prevention, and outcomes management. Although my job today as an MCS is very different than what a nurse does on a daily basis, I work very closely with nurses and PCTs to ensure that they are following our policies and procedures, focusing heavily on infection control practices. I strongly believe this when I was a nurse on the floor, and I try to instill this in my nurses today. We set the tone on the treatment floor. We are the leaders. If our team see us breaking infection control policies, they will likely do the same. So as a nurse on the floor, we must ensure that we are following policy and procedures every day, every time. Here at DaVita, we have created a culture of see it, say it, and have encouraged our teammates to hold each other accountable. We all forget. Things get busy, so we all need reminders on the importance of good hand hygiene in order to prevent bloodstream infections in our dialysis patients. We have to have a safe environment where we can hold each other accountable. Healthcare workers are the most common vehicle for the transmission of healthcare-associated pathogens from patient to patient and within the healthcare setting. Studies show, on average, healthcare workers clean their hands less than 50% of the times that they should. We might need to clean our hands as many as 100 times a day during a 12-hour shift. That means that there are so many potentially missed opportunities. Practicing good hand hygiene is a simple yet effective way to prevent healthcare-associated infections, and it is one of the best ways to protect our patients and each other. Wearing gloves does help reduce the risk of contamination, but we still need to perform hand hygiene after every glove removal. In most cases, you can use hand sanitizer because it is effective at killing germs on the hands. It requires less time than soap and water, and it is readily accessible. However, we do need to use soap and water whenever our hands are visibly dirty, before eating, after using the restroom, and after a known or suspected exposure to specific bacteria or spores such as C. diff. So how can we prevent infections in our dialysis patients? Following basic infection control practices, hand hygiene being one of the very most important. Following our policy and procedures that are put in place to protect our patients and our teammates. Creating that culture of safety, a safe environment where we can hold each other accountable, and creating a place where you would be comfortable treating your mom, your dad, or your child. And then complete continuing education. I had a patient attend one of our new teammate classes to share his dialysis journey, and I asked him what advice he would give to our new teammates, and he said, never stop learning, never stop asking questions. So I give you that same advice today. At DaVita, one of the tools we use is the facility safety tool. This tool is used to assess the clinical's high-level safety and survey readiness. For example, we look at physical plant, infection control practices, and teammate training. This audit is performed by myself, the regional operations director, or the home program manager. We complete this quick audit on each facility twice a year, or whenever we want to dig deeper into the facility's practices to ensure that they are survey ready. We also have the infection control quick reference guide that teammates can refer to for guidance on topics such as hand hygiene, the use of alcohol-based hand sanitizers, fingernail guidelines, and the use of non-petroleum-based lotions. It explains PPE use, how to put it on, how to take it off, how to properly wear it, and how it should be stored. It then goes on to discuss the disinfection of surfaces and equipment. The dialysis machine and its components may also be a vehicle for patient-to-patient transmission of bloodborne viruses and pathogenic bacteria. The external surfaces of the machine are the most likely sources of contamination. We need to pay special attention to the wall boxes to prevent the growth of gram-negative organisms, and remember that the wall boxes should be part of the routine station disinfection between each patient treatment. And as Brittany mentioned earlier, perform hand hygiene after every contact with the wall box. All equipment at the station should be cleaned between each patient use. I teach my teammates to look at the station as a room, and anything within that room needs to be cleaned, even if the patient didn't use it, such as the O2 concentrator. The quick reference guide also includes information on the chain of infection, focusing on contact transmission, which remember is the most common means of transmission. And because in an environment where multiple patients receive dialysis concurrently, repeated opportunities exist for person-to-person transmission of infectious agents. It then discusses bacteria in the environment. It includes a table that explains how long each type of bacteria can live on inanimate surfaces. For example, C. diff has a duration of up to 5 months. This can therefore be a continuous source of transmission if not regular preventative surface disinfection is performed. And now I will turn it over to my teammate, Michelle. Thank you.
Thank you, Kelly. Good afternoon, everyone. My name is Michelle Murtha, and I am the clinical nurse manager at DaVita Dialysis Center in Tallahassee, Florida, which is a 27-chair station that includes an active isolation room for our hepatitis B positive patients. I have been a part of the hemodialysis setting since I was a little girl when my father, who was the first nephrologist in Orlando, Florida, opened up the first outpatient dialysis center in the 1970s. I worked as a patient care technician at a time where needle and sharps were not well regulated, and we used cut up bleach bottles as our sharps container to discard fistula needles. I worked as an RN during the HIV/AIDS crisis, and I saw the first central venous catheter patient be admitted to the outpatient dialysis clinic setting. Infection prevention procedures and state and federal healthcare regulations did change for the best, as each of these milestone moments made their mark in outpatient dialysis clinics. Today, I will be talking about my role as facility infection manager, and to me, it all starts with water. Water is everywhere in a dialysis facility. Each dialysis facility must have a water purification system in place to produce dialysis quality water free of minerals, bacteria, endotoxins, electrolytes, and other debris. Dialysis quality water is the life of a dialysis clinic. Without properly treated water, the risk of potential bloodborne and waterborne illness, infection, serious illness from electrolyte imbalances, and death can occur to our dialysis patients. Part of my job is to make sure our teammates are completing and documenting safety checks throughout the day, from the moment the water comes in from the city to when it goes down the drain. These checks include initial startup and every 4-hour chlorine and chloramine water checks, and bicarbonate and acid mixing preparation and documentation. It is important that teammates properly prepare 1 to 10 and 1 to 100 concentration of bleach water for cleanup of blood spills and for use to disinfect the dialysis machines, chairs, wall boxes located behind the machines, in between dialysis treatments and at the end of day closing. Our biomedical technician performs and documents monthly end-to-end system disinfection, which requires follow-up of the direct patient care teammates to test all machines and specific water outlets for the absence of disinfectant prior to the start of the next treatment day. Prior to system disinfection, water cultures are drawn from water outlets and specific machines to ensure bacterial and endotoxin counts meet DaVita and AMI standards. Direct patient care teammates perform and document nightly heat disinfection and weekly bleach disinfection of all dialysis machines. All of these procedures require supervision to make sure they are done and done correctly. Continued and ongoing communication, training, and audit of teammates with regards to hand washing, hand hygiene, PPE adherence on the treatment floor, and the proper use of glove is so critical in my role. Vascular access and CVC preparation is extremely important in infection prevention in any dialysis clinic. So much so that at our clinic, we have 2 large posters at each end of our clinic to remind teammates and patients how to prep accesses and what is the drying time of each agent used to clean accesses. Our policy and procedure for CVC dressing change and treatment initiation has 7 times where glove change and hand hygiene needs to be completed. There is even a policy and procedure for how to rinse back, disconnect, and recirculate the bloodlines for bathroom breaks during patient dialysis treatments. Anytime bloodline connections are disconnected during treatment, the risk for bacterial contamination can occur. Monthly infection control audits are done. And with these audits, it's important to impress upon the teammates that at any point during treatment preparation, initiation, interruption, and discontinuation, the possibility exists for infectious material to break through and pass to the patient, particularly when policy and procedures are not followed. As a leader, I must set the example, as actions sometimes speak louder than words. I am constantly on the floor to help out with problem solving and just simply to be there during turnover periods when teammates may tend to rush and not adhere to policy and procedures. Whenever I have a patient with a suspected bloodstream infection, my first thought is if it could have anything to do with exposure to contaminated water or from a break in bloodline connections during the dialysis procedure. Was there a break in vascular access CVC care? Was the patient showering at home with the CVC? How is patient cleanliness? Is PPE being worn properly and are gloves being changed properly? And is the dialysis station and medication counters being wiped down with 1 to 100 bleach solution? The dialysis machine and external surfaces of chairs, counters, waste containers, and loose items around patient stations are all vehicles for patient-to-patient, staff-to-patient transmission of pathogenic organisms. Patients are reminded to wash blankets and clothing regularly and anytime they are soiled. Efforts are made to reduce water splashes from around clean sinks with the use of splash guards. Again, water is everywhere in our clinic, and where there is water, we know bacteria, viruses like to thrive. The results of water and machine cultures, infection control audits, bloodstream infection incidents, and hospitalizations are reviewed and discussed during the monthly facility health report meeting with our medical director. Since our dialysis clinic dialyzes hepatitis B positive patients, I, along with our vaccination nurse, must routinely review hepatitis B antibody and antigen status of all the patients to ensure Hep B immune patients are placed in pods that separate non-immune patients from Hep B patients in the isolation room. All patients are offered and strongly encouraged to get hepatitis B vaccination. Patients and teammates also get yearly PPD testing as part of the annual tuberculosis surveillance program. Pneumonia and yearly flu vaccines are also administered to patients. DaVita still implements COVID-19 entrance screenings on all who enter the clinic and advanced screening on all patients suspected of COVID-19 infection. Our COVID-19 positive patients are dialyzed on a separate shift where patients and teammates must wear N95 masks in addition to standard PPE. Finally, I spend a lot of my day communicating with patients and physicians for changes in patient status and following up on hospitalizations. It is important that there is a clinical nurse manager working together with teammates who can observe and pick up on subtle changes in our patients that might indicate an infectious process, considering the multiple comorbidities typically present in our patient population. Wounds, upper respiratory infections, urinary tract infections, changes in vascular access integrity, as well as in CVC exit sites, are a few problems that, if not caught early, can lead to potential bloodstream infections and hospitalization. For these reasons and many more, hemodialysis patients and teammates are always at increased risk of potential contamination with blood and pathogenic organism exposure and require more stringent infection prevention policies and procedures, such as the ones that are put in place here at DaVita. Thank you.
All right, thank you, everyone. So now I'd like to have our speakers turn on their cameras, and we're going to begin the panel discussion part of today's presentation. And I apologize, I'm using two screens so I can see everybody and my questions that I have. So while they bring up their cameras, I want to thank everybody for their wonderful presentations and for taking time to share their experiences with us today. That was really great. For those listening today, please remember to use the Q&A function in Zoom where you can post your questions. I've seen a few come in already, and we'll get to as many of them as possible after the panel discussion is over. So I'm going to start with our first question, and I'm going to direct this toward everyone, but I'll start with Michelle because you were the last one to talk. So when you were presenting, you each talked about how your roles support infection prevention, but now I'd like to ask, how do your roles interact and support each other to perform infection prevention practices? And you're still muted, Michelle, I'm sorry.
Hey, I would say from the moment the patient walks in the door, we as a team already start from the initial time that our administrative assistant is sitting at her chair and greeting them. We still do that COVID-19 entrance screening. So our AA is the first one there to alert any of us on the team if there is a change in that patient's status, whether they have a cold, wound, or cough. We're alerted to that, and they go into my office where I do an additional screening. In addition, our social worker and dietitian are also part of our team. They're the ones that come and help wipe down the doors, the handrails, the chairs in between all of our shifts. So they're working with us together. The dietitian will often talk on the phone with patients and patients' family members who will be alerted to a possible wound or something that the patient won't necessarily tell us when they come and sit in the chair because they're afraid that something else is going to happen and they're going to be there longer. So our whole team is constantly involved because these patients become our family and we all want what's best for them. And I find that together our team is very good in addressing all of these issues with them.
Those great examples of using those other staff that we didn't mention yet today. That's great. How about you, Brittany?
I would have to say just holding each other accountable and then also feeling comfortable to do so. I think that's the environment that we just foster at DaVita. We are very comfortable giving each other feedback, and then we act on the feedback that we give each other as well. Just the follow through, holding each other accountable and holding ourselves accountable, because we are here for the patients. We are the patients' advocates. So we do everything we can to ensure they're well taken care of.
Great. And lastly, Kelly.
I don't know that I have anything additional to add to what Michelle and Brittany said. I think teamwork is really important. And I think creating that culture where we are comfortable holding each other accountable, whether you're a nurse to a PCT or a PCT to a nurse or even a dietitian and social worker. So I think it's just creating that culture where we can hold each other accountable.
Okay, and that actually leads into my next question very nicely. So Michelle, so Brittany and Kelly just talked about holding people accountable. So what is the typical staff response when you hold people accountable, and can that be improved if it's not received well?
I generally find that most of the teammates are not bothered too much when I call them out on a task that they're not performing properly. I generally will pull them aside. I don't like to confront anyone on the floor, particularly in front of a patient. But afterwards, we will talk about it. We'll talk through it. At first, I might get eye rolls and saying, yes, but I do get a follow through when I explain that it's not just their safety, the patient's safety, it's also their safety that I'm concerned about, and that we're here for them. We generally will do follow-up. If someone's not performing and I have to go back and readdress the issue, we will then go through the skills checklist that we normally do on an annual basis, and we'll go over that again and explain in detail what they missed and what they need to improve upon. But I say in general, they're very accepting of my redirection, as I would call it. And then we reward them here for good behavior. I have a facility administrator who likes to feed our staff, and they are very excited and want to do well so that they can get that luncheon. So.
Oh, that's great. Everybody loves a lunch, right? Okay, the next question is for Brittany, and bringing us back to why we're all here, which is the patients, right? So how do you involve your patients in infection prevention practices, and how can that be improved?
Well, continuing education for infection prevention creates a consistent standard across the board. The patients know what to look for when the clinic staff takes care of them. They have autonomy over their treatment and health, along with knowing the why behind what we do. Keeping the patients actively involved in their treatment provides them with a sense of control over a situation that could feel overwhelming at times. And infection control starts with the patient, maintaining a clean site, proper hand washing techniques, but it's our responsibility as healthcare workers to educate and be the first line of defense in protecting our patients from infection. And I think everybody could always improve, right? But that's why we foster that continuous growing, continuous learning. We could always get better.
That's great. And you see them so often, you build those relationships with them. So that's really, really wonderful. Okay, the next question is for everyone. And I'll start with Kelly, since you were last time. From your perspective, what is the easiest or most efficient infection prevention technique that reduces the spread of infections?
Oh, most certainly hand hygiene and glove use.
Brittany, anything to add to that?
Oh, yeah. And then also just adding, hand sanitizer. We have it available at every turn in our clinic. There is no excuse. We have it everywhere. That's why, it's just readily available. So hand washing along with that, and maintaining, that consistent education of infection prevention.
Okay. Michelle, anything else?
No, I have nothing more to add, because I believe it's the proper changing of the gloves and the hand hygiene followed. They work jointly together, and that's the best. Yes.
Thanks, everyone. This next one is for everyone also. So we all get busy, and everybody perceives that they don't have enough time to do things correctly. Sometimes we take some shortcuts that we shouldn't. So what is one key takeaway you would like to share with the audience today to reinforce that adherence to infection prevention practices are important? And I'll start with Brittany.
Well, what I like to say to my team right now is I'd rather it done the right way and us be a little bit behind than us take shortcuts and hurt our patients. I would hop on the floor anytime before I would let somebody take a shortcut. I think that that's just, you know, very important that we just do it the right way.
Perfect. And Kelly?
I mentioned earlier in my presentation that I felt like the nurses were the leaders on the floor and that they set the tone. And I really encourage my nurses to, if they look up and they feel like the treatment floor is chaotic and things aren't getting done and vital signs are late and stations aren't getting cleaned appropriately, that they have the right and that they should stop production, like stop all tasks, gather everybody around, let everybody take a deep breath and kind of regroup, because we all know that when we get busy and chaotic, that's when things happen. And so that's what I would leave with today, is just take charge of the floor.
Yeah, that's a great suggestion. I think we all try to move faster and faster and faster, and you know, having that power to slow everything down and say, let's take a breath, that's very important. Michelle, did you have anything else to add?
I just like to say that I talked to my teammates about how it's important that we keep the patient safe, because they are sitting in a chair which requiring this life-saving procedure in order to continue to live so that they can continue to make memories with their family. And so I impress upon them that we are here for them. And the best way that we can help protect them is to follow these best practices for infection prevention. And that's why we do these things that we do. And you as the teammate are here to help us get that done.
That's great. Bringing it back to the patients. You know, that's why we're all here, right? To help save their lives. All right, we're winding down the questions, but I have a couple more. So this one is for Brittany and Kelly, and I'll start with Brittany. So thinking back to the ICAR data that I shared earlier in the presentation, why do you think routine station disinfection had the lowest compliance during the observations? And do you have any tips or techniques to ensure that all of those steps get followed?
Yeah, so I would have to say just the thinking of, oh my goodness, I'm behind, and just, you know, I think it all comes down to the techs and nurses thinking that they're just constantly behind and always trying to catch up. What I did at my clinic to ensure that they do not feel that way is adjust the patient's schedule a little bit, you know, just maybe space them out a little bit more or adjust the breaks. I adjusted the schedule to fit what my team can manage and what my team felt comfortable with, along with what was the best for the patients. The patients have noticed a great difference since then. Yeah, they could tell. They could sense that. So I think just, you know, spacing the patients apart, having an efficient schedule is definitely something that could help that feeling.
That's a great recommendation. And knowing your patients well enough to know who needs a little bit more time. Yeah, that's very important. Kelly, anything to add to that?
The only thing I would add, I completely agree with Brittany. The only thing I would add is maybe just having the patients wait in the waiting room instead of coming out onto the treatment floor. I think that adds some unnecessary stress to our teammates when you have a patient standing there tapping their foot wanting to sit down in their chair. So I think that's one thing. And then just get your teammates to think, would you sit in that chair? And would you have your mom in that chair or your child in that chair? And if you wouldn't, then we need to rethink our station cleaning. But I think those two things.
Oh, that's a great point. Kind of personalize it a little bit. So if they think that they wouldn't put their mom in that chair, yeah, no, that's a great point. Last question, and this one's going to be for Michelle. So as a facility leader, what can we add to the staff training process to ensure long-term adherence to best practices, and how can those practices be maintained?
I feel that a course on microbiology, which we touched on infection control, but I feel that maybe an annual course on microbiology and pathogenic organisms would help new teammates, particularly patient care techs, certified healthcare technicians that don't have previous healthcare experience would benefit from. And that new nurses would benefit from. We go to nursing school and we get that one microbiology course, and then everything's done. But we still need to know about E. coli. We still need to know about Klebsiella pneumonia, Pseudomonas, and their impact, and MRSA, and all those organisms. We can't forget about them because they exist in our environment. So I know with DaVita right now, we have our fall and spring updates where we'll get updates in our infection control procedures and any changes in any of the procedures. And then we also have our annual skills checklist. And then we have at our access to DaVita, any STAR learning course that you want to do that you're interested in. So to have time for actually other nurses to be off the floor to do some additional training, because we all know our 12-hour day is full on the floor, but there would be nice time to add into a teammate schedule these times that they can come in other than their day off to do some skills training and updates on the computer so that they know and understand what these pathogens can do to in our clinic setting.
Thank you. Those are great ideas. We're at 4 till the hour, so I want to stop us here to make sure we get to answer some of the questions that have been put into the Q&A box by those that have been listening. So I am going to stop here and hand things back over to Stephanie to see if there are any posted questions.
Yeah, thanks, Nicole. There's actually been quite a few, and I'm thinking we can get through some of them. I think the first question is targeted towards you, Michelle. They're asking if facility IPs share specific NHSN or other BSI data with staff on a regular basis.
We will do it during our daily communication. We have a homeroom meeting, and if we have issues that we need to address, we have an actual communication book that as part of the start of the day, I will go in there and discuss blood culture results, follow-ups that need to be done, hospitalizations, what the patient was in for, what we need to look out at, because I'm not necessarily here at 5 o'clock in the morning every morning. I'm the one who's following up, but we communicate through that communication book so that everybody knows. If our medical director has specific issues he's concerned about, I will follow it up with the communication book. And that has been a life-saving piece of material in our clinic. Thank you.
Yeah, it sounds like a great tool. The next question, I think, Kelly, you could probably answer this, but I also think that, Michelle, you mentioned this as well. But it says nurses need to be great leaders. Is there a specific example you can share to help me be a better leader?
Oh, that's a tough one. I think just the number one thing is, I think, building that relationship with your team and having a trusting relationship where they feel like they're comfortable coming to you. Nurses make mistakes too. I touch the machine without gloves accidentally sometimes too. And I need to create an environment where my PCTs are comfortable coming up to me and saying, hey, I saw you touch that machine without gloves, and not feel like it's going to be taken defensively. So I think I would say build that really good relationship with your team.
Great, thanks. And I think we have time for one more if we do it quickly. Brittany, this one is for you. You talked about that taking time to do things correctly is better. So maybe can you give us an example of maybe how you might do that when you need to get a patient on a machine quickly? Let's say they have an appointment, or other staff who are actually encouraging other staff to go faster.
You know, what I do on the floor whenever I find myself in that situation is ask my teammates for help. I think sometimes we're scared to ask for help whenever we shouldn't be. I tell the team all the time, like, we're only just right there, right across the floor. It's so easy just to be like, hey, can you come over here and help me out with this? Can you do this while I get this patient on? I think just reaching out to your teammate and utilizing all the tools at your disposal here is a good way to do that.
Perfect. Thank you. I'm actually going to share my screen again. And before I do that, I just want to start by, thanking each of our presenters today. It's been great that you guys have been able to share your experience and your expertise with us. It's been very informative and educational. On this final slide, you can see more information on how to obtain the CE credits for participating in today's webinar. You'll need to visit tceols.cdc.gov and sign in or create a new username and password. You'll search for today's webinar and you'll enter the following information that you see on the screen. You'll then need to complete an evaluation as well as a post-test to receive your CEU. And a couple of other questions that we actually got in the chat box was, how do we reach out and ask questions about the CDC tools or the ICAR tools? And so here on this last slide is actually the email to the Dialysis Coalition at cdc.gov. You're welcome to, if we didn't get to your question, to go ahead and follow up with an email. And feel free to reach out to us if you have any question or comments that you would like to share regarding today's webinar. So have a wonderful day and thanks again for joining.